Kevin Mullins, and I'm the Programme Director responsible for driving the national part of the programme. But essentially what this is all about is actually getting local delivery systems in a place we need them to be. Have I just got it out? Right hand button, very good. There you go. Now, this is all about this stuff. It's all about depression and anxiety, which is unbelievably commonplace. So the estimates we're working at the moment, there are in excess of 6 million people, adults, in this country at any one point have got some form of common mental health disorder as it's classified. Usually that means an anxiety or a depressive disorder. And there's various forms of severity. So it's a very substantial problem out there. I think the NHS, the Woodrow spent lots of time worried about the more severe mental illnesses, so schizophrenia, bipolar, and so on and so forth. And quite rightly so, because those are devastating to the individuals and families and communities that are involved in that. The incidence though is quite low, 1% of the population at any one time. So the numbers are dwarfed by the numbers of people with common mental health disorders. So 6 million people pays off about 350,000 of them. The other thing which is, I want you to take away from today if you will, is the fact that for common mental health disorders, anxiety and depression, there are some very, very good and effective treatments, which have been approved through various testing processes and clinical trials and so on and so forth, by a thing that we use in the NHS to validate effective treatments, thing called the National Institute of Healthcare and Excellence, NICE, which is the acronym that appears on there. And there are various treatments that we think are associated with that. So CBT, cognitive behavioural therapy, is the critical one, and the one that we've been mainstreaming into services for a while now. But there are various others, and there are treatment variations. So EMDR is eye movement desensitisation and rationalisation, I think, and post-traumatic stress disorder is a form of anxiety disorder, and it's a very significant one, which I'm sure you're familiar with. The therapies are listed there that we apply. So we largely use a behaviourist approach to treating anxiety and depression. So that's the cognitive behavioural therapy and its derivatives. But increasingly, NICE has approved other forms of counselling and psychotherapy. So interpersonal psychotherapy is one that's NICE approved. Couples therapy, counselling, and brief dynamic psychotherapy are all forms of appropriate treatments for depression, as it says there. So the other thing that's quite interesting here, despite the fact that A, this is a huge issue, and B, there are treatments that are available, and we haven't addressed the need through those treatments, for the most part, most people prefer to have a psychological therapy. So for those who access treatment, I realise they've had a problem and visited their GP, prior to the introduction of the programme, largely people will be treated with antidepressants, despite their preference would be to get a talking therapy in many, many cases. And the killer argument here, which is put forward by particularly Richard Layard, who Lord Layard is an internationally renowned economist, and that's quite significant because he drove this as an economic argument. Large numbers, largely in employment or about to fall out of employment, issues associated with getting people off benefits, treatments available, economic benefit and flow from that. And that's his basic argument. The treatments are very cheap, very effective, and they can turn people's lives around and turn the economic future of this country around. And he's won that argument very successfully in all sorts of places, across government, across parties, and he's effectively the founding father of this whole movement. He and a chap called Professor David Clark, who provides the clinical wisdom and the gravitas behind all this, have worked as a pair tirelessly to make this happen. So, these are the list of the treatments that are available for the various disorders that we treat. So those are NICE approved, so I'll reiterate what I said earlier. This is the principles upon which we are pursuing relentlessly the transformation in people's experiences of healthcare at this end of the spectrum. So making sure that all services that are out there are NICE compliant and they're safe and effective and so on and so forth. That services are actually populated by people who are effectively trained, supervised and accredited in delivering those treatments. So 6,000 new therapists have been created to make this happen. And then what we do is absolutely novel in healthcare. We actually relentlessly capture the information from people about their experiences of treatment at every session, and we report it, we gather it together, sift it, and we report it publicly. So if you are ever unfortunate enough to be anxious or depressed and think you may need help or treatment, and you want to know where to go, You can find out fairly rapidly now where the effective treatments are by going into a slightly cumbersome set of spreadsheets at the minute, which are contained in the Health and Social Care Information Centre's website. So put in IAPT and you'll get a huge amount of data. We're turning that into something a bit more user-friendly with our friends from NHS Choices, so you can get some increasingly useful information from that source, and also our friends in Public Health England, who've turned it into a much more comparative version of that data in terms of clinical outcomes achieved at CCG, clinical commissioning group level, or provider level, i.e. the services that you're actually running, and delivering the services. So that's really quite a novel thing to say, and as I say, it's novel it is unique in terms of what we are doing in terms of capturing data this relentlessly, and it's pretty unique in being able to publish it. So that's quite significant. Just to remind you, this is a sort of very quick picture of what we're trying to do here. So if you think about pouring in the 6 million people in need, in any one year, by the end of this Parliament, by March 2015, we will establish sufficient services to address 15% of that need on an annual basis. 900,000 people being able to access treatment. So it will work something like 1.2 million people are referred, because there are various issues about whether they are acceptable for treatment or accept the treatment that's offered. We think at least 25% might drop out, 900,000 start a course of treatment, roughly 2/3 complete, and half of those recover. So the key metrics here, which are in the NHS mandate, is achieving on an annual basis services that can cope with at least 15% of the need against the 6 million, and will work through in a systematic way, delivering nice guideline treatments to deliver 50% recovery rates for those who are in treatment. And to pay it, we expect those people who are coming off benefits to be in the region of about 25,000 by virtue of being put back into a place where they can think about their lives again, think about employment and so on and so forth. Why only 15%? The logic of this is something like, there is probably an envelope with some of this on, but the guesswork that underpins some of this is around, if you've got 6 million people, probably only about half of those know that they may have a problem. Half of that half are likely to seek help. And a proportion of those would prefer to get medication, for example. For a few of those might actually go to other non-NHS sources as well. So 15% in relation to the 25 is about right, we think. We will get there, but I don't think we recognise the job is not complete yet. And I know Richard and David and his colleagues are pushing for a much higher aspiration, towards, say, 25% of that 6 million. We're also doing a lot of work now to extend the offer into other places. So take some of those basic principles about compliance with a set of evidence-based standards, training a workforce and reporting on outcomes, and also thinking about other things in people's lives, employment in particular in the case of adults, participation and cooperation, collaboration in terms of how children's services develop, and various other aspects of what we are considering are appropriate in a local context. So the service model varies slightly, but we're exploring how we would transform child and adolescent mental health services. So we have a particular set of initiatives in that area at the minute. We're looking about how we might influence with some of this paradigm secondary care mental health services. So going back to the group that's had quite a lot of attention, but perhaps not enough just yet, those people with severe mental illness. And then thinking about the relationship between people who have long-term physical health problems or medically unexplained symptoms, people who have things that are actually not quite sure what it is, but it's affecting their daily functioning. And there's probably some psychological aspect to that. So combining the mental health provision around psychological therapy with the physical health provision to make it join up and address, if you like, what we call clarity of esteem. So making sure that mental health services have the same level of focus, attention and resources as physical health services have for some time. And there's some very interesting models that we're developing in that space to bring together an appreciation of the mental health aspects of the problem with physical health and actually make for a rounded assessment and a rounded treatment set of options for people. So we haven't finished the job in any way of doing just the basic stuff to address the 6 million, but we think we can go a lot further and actually achieve a lot more transformation to people's experience of healthcare more generally. That's all I wanted to say at the minute, and I'm probably happy to take questions that might be more interesting than me just spouting.
Yes, we've
economics and the economic argument.
I understood that the initial argument was based on the premise that IAPT will pay for itself with the numbers of people moving off sickness benefits, so wouldn't effectively need any government money to underpin it. When I had a look at the statistics, over a 3-year period, 45,000 people only have moved off benefits and not necessarily into work. I'd be interested to hear your comments on how many of those people would have moved off benefits anyway, and actually from a broader economic perspective, what is the added value of IAPT using Richard Layard's original premise?
Okay, that's it. The data you're quoting, I think, is probably from our 3-year report.
Yes.
So things have moved on, with best part of 80,000 people have now moved off benefit. I totally say about the dead weight effect, as they call it, so would they have got off in any case without any interventions? And actually we don't know the answer to that. There's been a couple of attempts to try and establish what might be happening, and there's a particular set of initiatives right now trying to get to the bottom of some of that. So I haven't got a conclusive answer to that, and I don't know whether we ever will, to be frank. It's a bit of a tricky one, the contrafactual sort of side of things. The principle, I think, still stands. So at the end of this, so leaving aside economic art just for a minute, but I will come back to it, I promise. The cost of IAPT is tiny in terms of the overall spend on healthcare. So if you think about the 110 billion that is spent, the annual recurring cost expenditure on IAPT, when we have got to the 15% level, will be something like 330 million. And if you think about the volumes of people that is benefiting, and the undeniable benefit, I think, of those people, if you were asked them, and we have, about that, I think that's substantial and a very good investment of public sector money, I would say. We are tracking those benefits, and we can see a return, but it's a return that DWP, the Department of Work and Pensions, get benefit of. And they are very clear that actually there is a benefit there and are very supportive. So the principle is sound. We will be doing Department of Health rather than HSE, will be doing a formal evaluation and appraisal of the programme as a whole. That will be quite complicated to do, and it is a challenge. But I would be confident that, and bear in mind what I'm saying about the performance overall, the benefits to society overall, and the changes in the numbers coming off benefit, and the individual pieces of work we've done around employment, that we will be able to say, here is a good thing we have done, and here are the returns on it. But I take the challenge.
Dave Eager, I'm from Union Learn, which is the TUC's Learning and Skills Arm. Two different questions. The first one is, we have a huge number of people suffering from stress, anxiety and depression in work, who find great difficulty getting access to IAPT services because of the length of time to get in, etc. Wouldn't it be a really good thing to start bringing some of this into work and closer to work and doing more with employers and ourselves to get access, because that might not get people off benefits, but it will stop them getting on and losing their jobs, and it will also increase productivity. And the second one is, this all looks a bit old, Pat. We just had a look at what's going on in Australia and New Zealand with a lot of online CBT and online access to services as well. You didn't mention anything like that in your plans, and I would have thought that would make a huge difference to how things could be delivered.
Two things. We are working very closely with the DWP about the developments in occupational health provision. Some of the pilots I mentioned around employment have a focus on that. When we started the programme, we anticipated, and it's still an absolute quality standard for us, that there should be employment support advisors within the services working alongside clinicians, because it's entirely complementary. And in fact, if you don't have employment support, you tend to have more expensive therapeutic costs. So there's an absolute benefit and a trade-off there, which we expect to see. Our latest census illustrates that we didn't we're nowhere near the 1 to 8, so that's one employment support advisor in an IAPT service to 8 practitioners. We're way off that in there, and that's a concern. Doesn't mean to say that there isn't other ways and means where some employment support has been provided, either externally contracted, or in some cases some of our low intensity workers have picked up that brief. But the numbers don't look promising from that point of view, and that's an issue we're reflecting back to services now, which deeply. On the online thing, it's absolutely part of the offer. The long-term condition stuff that I just mentioned is largely, the most exciting bit that I've seen was a Skype-driven approach to it, particularly for people with restlessness, housebound and so on. Being able to having a domiciliary assessment, then accessing the therapy in groups via Skype and It's like actually Skype say page, allegedly that's more secure, I'm not sure about that. So that's really exciting. A couple of our individual IAPT providers are exclusively online. So tiny numbers. So if you go on Psychology Online is a national outfit. They do it remotely at any hour of the day or week, and that's the advantage of it. They do it at reasonable cost because they can outsource it to all sorts of interesting places. It is quality assured because it hits our standards. And it's the way to go for people who can do that. Certain communities, the deaf community in particular, for example, there's incredible high levels of morbidity, but dispersed throughout the country because there's a small concentration of that group in any case. And we would advocate very strongly for online provision of those sorts of groups and how. We work with the Big White Wall, which is part of Tavistock and so on. There's plenty of good examples of how we've taken new technology, applied it, and it's a long-standing. There's nothing to get away from me about having a core of services that is able to deliver the face-to-face assessment and the follow-up if necessary. But using different approaches to delivery is absolutely what we're about. Apps, there's a huge number of apps which are available as well, supported by us. And, yeah, you're absolutely spot on. If we don't do that, we will certainly not get to the 900,000 effectively with the limited amount of cash.
Okay, brilliant.